Oftentimes, this semester allows you to really internalize those muscles, because last fall when we were talking about the shoulder, your hair was on fire, right? And trying to learn all 20 muscles was really hard. So this is an opportunity to go back, like take a deep breath and really tighten those up so that it's there. So this is the format of the quiz. Beginning lab, 6 multiple choice, intended to get you ready for the exam. 2 OIAN, 1 motion analysis. This is when the 20 stabilizers start. But you can draw from anything you want. Like if the person's standing, you can use all the postural muscles. You can use the trunk, you can avoid the trunk. If they're holding something, you can use all the grippers. 20 stabilizers, and then 1 surface anatomy. I mentioned this the first day of the semester, but I think it merits repeating. You're gonna be doing electrical stimulation with Dr. Brickley, and it's really helpful if you're trying to stimulate the ECRL and ECRB to know where they are. Right? If you're trying to stimulate in isolation the infraspinatus, it's really nice to know exactly where it is. So we cover the surface anatomy here, but you're going to apply it when you're doing E-stim and applying electrodes to your patients. I want to just review the musculature that we can see superficially. So take a moment, see what you can identify. We're going to use Ronnie Coleman on the left for both images, just for consistency, because I got a roof shot of him as well. So see what you can identify pretty much in that general region. Striations, yeah.
Eat cereal out of that.
So, clavicle, right? It's a nice landmark to kind of work off of. What's right behind it and above it? Yeah, there's the straps right there. This kind of looks like it's the acromion process. It's kind of a depressed, flat surface. It's running right down here. Anterior delt. Most of this is going to be Coleman's really great for this. He's one of the people you can see the distinction between the clavicular fibers of his pec major. You can see pec major originates in this region. The clavicular fibers running straight up to the clavicle versus the sternal fibers running to the sternocostal region. So all that's pec major. Anything else superficially in the shoulder? In the front view? Yeah, a little bit of the posterior delt. Right there. Beautiful rounding, and right there. In fairness, if I was to put this on the quiz, I'd probably give you a rear view so that it's not at all ambiguous what we're pointing to. Same thing, take a minute and identify what you're able. Striations.
Oh, yes, that's all I'm looking at.
So,
I'm not even taking
No.
You got tied by one of the other bodybuilders.
The vodka? Is that what this is? Yeah, I did hear that.
And that's what shrunk everything up. You can see some of those on YouTube.
Yeah. All right, so again, really good view of the delt. The posterior delt coming here, the middle delt, and you can see a little bit of the anterior. The upper traps running into the cervical region up to the occiput. This is amazing because you can see the fiber orientation of the middle traps versus the lower traps. Different fiber orientation, hence their different function. Amazing view of what's that? I've heard three. It is one of the following. I heard in order rhomboids, infraspinatus, or teres minor. It's one of those I'm going to erase so that you can kind of appreciate the anatomy. Think about what is superficially visible. What do we think? Infraspinatus. Rhomboids, we have to peel this back. Rhomboids is deep to, rhomboids are deep to the traps. What lives in the infraspinous fossa? Infraspinatus. I mean, really nicely done. And you can appreciate from that elevated arm view how the scapula upwardly rotates. Because if his arms were down, the infraspinatus would be oriented a little bit more here. See what?
I can see what you want.
Yeah, right? 1 8 times.
Everything is so fun.
It's also a nice distinction here. We can appreciate right under the infraspinatus, we've got one muscle, largest surface area in the body. Go into the thoracolumbar region. What do we have there? Latissimus dorsi. And then right above the latissimus dorsi, I think this shows why they function so synergistically. What do we have? Teres major. Now, the images on the quizzes are intended to be unambiguous. They're not all Ronnie Coleman, but the structures aren't on frail older adults that you can't differentiate. It may be a structure that's atrophied and missing, not missing, but truly atrophied, like what's wrong with this? And it may be the rock makes an appearance on one of the leg ones. It may be something really abundantly clear, but they're not intended to be ambiguous. Again, you can see the deltoids. I think we mentioned this. Posterior delt is better visualized here. Middle delt, anterior delt, upper traps, middle. Anybody see anything else that I missed?
The erector spinae muscles, maybe.
Erector spinae are hard to see here because superficially up top they're covered by the traps, and down below what we see is the striations of his thoracolumbar fascia, but this is super thin. So right below it, like if you touched it, what you'd be feeling is the paraspinal erector spinae muscle group. Yeah, right here. Long head of the triceps, and you can see it here as well. Which I think that kind of highlights how it, like the posterior delt, functions in extension, right? It kind of has that same line of pull on the humerus. The triceps acts with the lats and the teres major to bring the arm here. It's a long head of the triceps to bring the arm here. It's one of those anti-tickle muscles, right? If we're flexed, it extends. If we're abducted, it adducts. It just holds the arm tight at the side. Anything coming from this region is going to do that. It's going to hold us right here. All right, foundational surface anatomy good? Okay, so that's moderately a review from last term where we looked at a lot of pictures. And then OIAN flashcards, moderate review of last term as well. We'll cover everything on the reading worksheet. So if you didn't get full credit and you want to resubmit, or if I haven't yet graded yours and you just want to resubmit after class, that's fine. Even if you got full points, there probably are some comments if one answer was a little bit unclear, so please do check the comments there. All right, speaking of the worksheet, this was question 1, 5 joints of the shoulder complex. Our book last term Our book last term only covered 4 joints of the shoulder, so there's a little bit of difference as far as how sources describe the joints of the shoulder. Regardless, there's multiple joints. We generally think of the glenohumeral, the ball and socket, as the primary one, or it's synonymous with shoulder in popular culture. But there are 5 according to this text. 3 are synovial joints, 2 bony ends, joint capsule, and free movement. Those 3 are the AC, acromioclavicular, SC, sternoclavicular, and GH, glenohumeral. And there's 2 functional articulations. In other words, there's not 2 bony ends connecting. As we knew first semester, one is the STA, scapulothoracic articulation, which is not held together at all by bones or by a capsule, it's just muscular. And then number 2, what's new this term is the suprahumeral, above the humerus, or subacromial, below the acromion space. This is an anterior view of the right shoulder, kind of looking through the skin. So we can appreciate the GH here, the AC here. The SC here is the only connection of the arm to the axial skeleton. It's the only bony connection. And it's part of why there's so much free movement at the shoulder. Very, very limited bony stability. This is the only spot. All right, starting with the AC. Hopefully, because this is the second time we've covered the ligamentous anatomy here, it's a little bit familiar. This term we will spend more time on the ligaments, whereas last term it was more muscular. So unlike the SC, which we don't really know what kind of joint it is, the AC is agreed upon to be a plain synovial joint. So anatomically, clavicle, acromion, AC joint right here. It is stabilized by a bunch of different ligaments. There's no muscular dynamic stability, but there is lots of ligamentous or passive stability. The superior and inferior, and in that image we can see the superior but not the inferior. Acromioclavicular ligaments live right here. They're supporting exactly what they say. The AC, the acromion, and the clavicle, giving it static stability. The coracoclavicular ligaments, from coracoid to clavicle, are right here. The coracoclavicular ligaments are on the medial side, the conoid, and on the lateral side, the trapezoid. Going from the coracoid to the acromion, we have the coracoacromial ligament. So just base anatomy, that's what we have. The coracoacromial ligament, along with the acromion process, this whole area, is what provides a roof over the subacromial joint. So the subacromial or suprahumeral joint's the space right here, and it sits right under, so far in the curriculum I've just said under the acromion process, but we're going to expand that just a little bit. It's not only the acromion process, but it's also the coracoacromial ligament. And it's depicted in figure 17.2, that's this picture, incidentally, in your text, and it just shows the roof of that space. All right, we see this very commonly in football. A fall, either on an outstretched arm, or more commonly a blow to the outside of the shoulder, which is like landing on this shoulder with somebody landing on top of you. If you land like that, it's very possible your clavicle is going to absorb some of that force. If you land on your side and somebody lands on top of you, that force is going somewhere. This is probably the region it's going to go. Best case scenario, fracture the clavicle. bones have a good blood supply, right? Well vascularized means great capacity to heal. Often, however, this isn't what absorbs the force. Instead, we see a rupturing of these ligaments. The clavicle gets displaced, and what happens is those ligaments rupture. Rupturing of these ligaments is going to result in an AC separation. It's that last bullet point. Acromioclavicular separation occurs when these ligaments are ruptured. So it's a hypermobility injury, and it's commonly called separated shoulder. More on that to come in the summer. But if that happens, if we think about these ligaments, rupture this, we rupture that. Those are holding the clavicle down. So which direction are we going to see it displace? Which is part of what leads to that step appearance of a separated shoulder. The clavicle is displaced superiorly because nothing's holding it down. But also, think about how far in front of our body this coracoid is. It sits way out here. It holds the clavicle anteriorly. So in addition to the clavicle popping up, it kind of pops back. So when we see an AC separation or a shoulder separation, the clavicle displaces up and back, superiorly and posteriorly. And it's not arbitrary, it's just because there's nothing holding it down and forward. Anybody know anybody or themselves have an AC separation? You?
No, my dad.
Yeah?
He got it from playing soccer.
Okay, and he landed on it?
Yeah.
Okay, so does he have that step displacement?
Yeah. He never got it fixed, you know.
So, how many years ago was this?
It's like 60 now.
Okay, so
Yeah.
it's decades,
Yeah.
and it still looks the same.
Yeah.
What does that tell us? That this doesn't just go away on its own, right?
Yeah.
So here's what happens. Like some ligaments, if you sprain your ATFL a little bit and you put it in a boot, it may scar down and heal back. But if this clavicle displaces way up and the ligaments aren't touching at all, there's going to be virtually no capacity to heal, right? But also, and this goes back to my earlier point, there is not a muscle that dynamically stabilizes this. And if your humerus pops out, we got the rotator cuff. You have an inversion sprain, we got the fibular or peroneal muscles. There isn't a muscle to dynamically stabilize this region. So he goes to therapy and we're like, well, we can do some things, but we can't do anything for this. And so sometimes individuals are just left with that step deformity of the shoulder separation. Sometimes they are surgical candidates. For example, at the time he was the starting quarterback for the Colts a year or two ago, Anthony Richardson sustained a grade 3 total AC separation, and it was on his throwing arm, and you can't throw a football if you have a separated shoulder. So there are individuals who do nothing, but increasingly we're seeing this as a surgical candidate. So that's the AC joint. Good? Yes, ma'am. Yes. So far, I keep saying that actually, let me jump to another picture and just develop that a little more. This is a lateral view of the shoulder, glenohumeral region. Here's the acromion, which sits over the subacromial space, but it's not just the acromion. I've been very simplified that over the last few months. It's also this coracoacromial ligament, which collectively with the acromion forms the coracoacromial arch. We'll get back to that in a minute. SC joint. Some of you on your reading worksheet put that it was a saddle joint, and according to this text, that's correct. According to other texts, it's not correct, so I don't really care if you identify what shape of joint it is or not. It's ambiguous, and because of that, it's not testable, and because of that, it's not really important. So it's a synovial joint. We don't really know what shape. It moves. Again, like I mentioned earlier, this is the only bony attachment between the axial and appendicular skeleton at the upper extremity. so it contributes to the great deal of mobility. Don't see a whole lot of patients presenting with SC issues, which is part of why we're being brief and kind of just paying it lip service. Yes, sir.
What's the reason we haven't settled on something? Is it like a competition, like two schools of thought? Like, is it some big hot heated topic?
Not this. There are some of those, and we'll cover one of the big ones this summer.
Because that drives me crazy. We're just like, yeah, it could be one of these.
No, like you just look at a few different sources and they just describe it differently, and they don't offer a rationale for why. You know, we have a more concave and a more convex partner, yeah, but there's a few of those, like between the atlas and the occiput. It's probably a condyloid, but you'll feel some ball and socket references. Sorry. I mean, if we don't agree, it's probably not a hill to die on, right? So call it whatever you want.
Yeah, put together some kind of concept.
Consider it a corpus. I mean, there is some of that rotation. All right, so the GH, this is, again, what we think about as the shoulder. We do know it's a ball and socket with a lax joint capsule. And we're gonna stop on this thought for a minute. With a lax or inferiorly redundant joint capsule is the language you'll see. Sometimes you look at something and it's like, what does that mean? And why do I care? Here's what it means and why we care. And we will come back to this. The joint capsule is not vacuum sealing the shoulder, which we've established as good, right? What would happen if all your joint capsules were like vacuum sealed? We have no movement, right? We'd have great stability and very poor mobility. So all of our joint capsules have some laxity. It's what allows for joint play to occur, right? Joint play is just describing like any mobilization force to the joint. We pull it apart because we have some joint play, because the capsule is not vacuum sealed. We need that, we want that. But the capsule in the glenohumeral joint is inferiorly really, really redundant. There's extra tissue in the capsule. Who cares? Nobody cares. So, this is going to be a segue. This is a good one. When I first got here, Mr. D hadn't come back, but his former person who had his role taught me this new anatomy term, and I felt really bad because I didn't know this term. He was sharing this with me, and it's not actually in atlases, but it's in the Urban Dictionary, so like, take it for what it's worth. Anybody familiar with this structure? Yeah, look, it's the weenus. Okay. The weenus is kind of like an inferior redundancy in the glenohumeral joint capsule. What would happen if I went in, or somebody went in and surgically removed all this extra weenus tissue and like cinched it down so that there was no more weenus? What would happen? This would be a big problem. I wouldn't be able to fully move my arm. Why do we care about the weenus of the glenohumeral joint capsule?
Because it gives us
Yes.
so like inferior line.
Yeah. So we need, in order to go from our resting position to 180 degrees of arm elevation, we need for that humeral head to do what? Slide or glide inferiorly, quite a bit, to allow for full overhead motion. So that lax inferior joint capsule provides enough laxity, enough movement capacity for that inferior glide to occur. So what would happen if we had a pathology that caused joint adhesions and restrictions and inflammation all on that antero-inferior aspect of the joint capsule? What would happen? We would have a whole lot of trouble with movement, right? So this is the anatomy behind the pathology of frozen shoulder that we'll cover this summer. In a frozen shoulder, and I'm going to show you a picture now, but we will not talk about it in great detail. In a frozen shoulder, this comes after the lab exercises, so again, everything past this slide is summer. In a frozen shoulder, you see this normal capsule, looks healthy, inferior redundancy, allows for great mobility. A frozen shoulder causes inflammation and adhesions, particularly in that inferior and anterior aspect. So this patient comes to you and yeah, it hurts, so that's a big reason. But also, what is he or she going to report? I'm having trouble with, why washing her hair? And it's by and large women, which is why I'm gonna use her. Why is that? Due to what two motions? External rotation and at the shoulder. And abduction. Well, in order to abduct, what directions does the humeral head go? Down. This is going to be problematic for abduction. In order to externally rotate, which direction does the humeral head go? Anteriorly. Going to be really problematic. This patient, yes, pain is a big problem. But also, I'm having trouble with this motor pattern. I'm having trouble raising my hands up overhead, particularly to wash my hair. So that one little line about the inferior redundancy, it's a big problem for our patients with adhesive capsulitis where there's a loss of redundancy. So more on that to come. It's the weenus of the shoulder joint capsule, yeah. My son's 9. He finds it a riot when we talk about the elbow weenus. Please don't say it in public. Mr. Tobin on it.
That's healthy.
It's a fun part, right? I mean, we don't have a term for it in the actual medical atlas. It's only in Urban Dictionary. It's set you up for failure.
This is what Dr. Miller showed.
So the next 2 bullet points, this was another question on your reading worksheet. What are the static and dynamic restraints of the shoulder? And again, like it's easy to read over, but then we'll talk about the future implications for why we care. So we've got static restraints. Static is synonymous with passive. These are the non-contractile things. They just hold the joint in place passively. If we're going to say the dynamic restraints, the muscles are dumb, but these are really dumb. Like they can't even contract. They just passively support the joint. And the support is provided by the bony partners. So the humeral head is convex and the glenoid's concave, but there is such limited stability there because remember, the humeral head is more like a golf ball on a golf tee. It's like 3 times the size of the fossa. So there's not a lot of inherent stability provided by the bony architecture. The glenoid labrum, it's that fibrocartilaginous lip around the glenoid. It deepens it. It provides for a little bit of suctioning and negative pressure there, so it helps. And then we've got our 4 ligaments. We've got the superior, middle, and inferior glenohumeral ligaments and the coracohumeral ligament. So 4 ligaments providing some stability. But if you have a shoulder dislocation, and we've talked about this a few times, it's most likely to be an anterior dislocation. And it's most likely occurring due to falling when the arm is in this position, rolling over it like this, a forced elevation with external rotation and hyperabduction. What's going to happen to these tissues on the front of the capsule? Yeah, they're going to rip. There are like two things that are going to help that. Number one is time. If the tearing is not complete, there is some capacity for this to scar down if the patient's immobilized. So lots of time. Or surgery, we'll talk about the procedure for suturing the capsule over the summer. But if you damage these static restraints, they're hypermobile. Only time and surgery are going to change that. And by themselves, the static or passive restraints, totally inadequate to hold the humeral head stable. Totally inadequate. We know this because individuals who have had a stroke, their humeral head starts to fall out of socket. And we talked about this, but I want to revisit the picture just so you've got a mental image of what the shoulder looks like without dynamic stability. This is one, we'll do two pictures. So this individual looking at her skin doesn't look like she's an older adult, she just looks like she's hypermobile. But you can see the arm isn't sitting as high as it should. It's dropping because of the weight of the arm out of the socket. Another one. We'll actually do this test over the summer. This is a Selkis test where the clinician pulls the humerus down to see if there's any gapping here. But in individuals who've sustained a stroke, the dynamic restraints, the muscles in their shoulder, tend to become very inhibited. And what happens is just at rest, the arm starts to take on this appearance and this posture. So by themselves, again, the static restraints are totally inadequate to support the arm. So in addition, we've got the dynamic or active restraints. And we see this at many, many joints. And this is primarily, not exclusively, but primarily the rotator cuff muscles, all six. And we told a partial truth about these last semester. Okay, so last term, we talked about how the infraspinatus, for example, attaches to the greater tubercle and can externally rotate the arm. That's not the only attachment. All six rotator cuff muscles also attach to the capsule. All six rotator cuff muscles also blend with the joint capsule. Who cares? Who cares? I care too. Why do we care? Why do we care that their insertion isn't just the greater and lesser tubercle and supra and infraglenoid tubercle, it's also the joint capsule. Why is that important?
So we know what's affected if it gets damaged.
What's that?
So we know what's affected if it gets
Keep going with that idea.
damaged.
Keep going with that. Why do we care? What happens, let me ask it this way. If the infraspinatus and teres minor, and the long heads of the biceps and triceps, if they all contract, what happens if they all contract? Yes, they add compressive force. But remember, if they're attaching to the capsule and they're all contracting, what do they do? Does it change the direction? You're going to be the supraspinatus, okay? Pull on that. This is the joint capsule. You're going to be the long head of the triceps. Pull on this. Okay, so uncontracted. A really limp, wrinkly capsule. Go ahead and contract. What did we just do?
Sorry.
We tightened it, thank you. We added stiffness or stability to the capsule. So the dynamic restraints, when they contract, they provide dynamic stability by tightening the static restraints. The muscles attach to the capsule, and so when they contract, they not only add compressive force to the joint, but they stiffen or tighten or enhance the stability of the capsule. I'm trying to say it differently. They stiffen it, they tighten it, they give it more stability. They enhance the stability. So in other words, if your patient came in after an anterior dislocation and has a significant hypermobility in the capsule, we can't do anything aside of time and surgery for the static restraints, but we can address all of the musculature that adds dynamic support and indirectly treat the capsule.
So without,
There you go, stretch. Yeah.
would that change their, if they would have the same measurements on passive range of motion, but then active range of motion, just because they
So for the sake of the question, let's assume an isolated anterior dislocation, because that's important. And we'll also assume that it's not super acute, and so any injury-related swelling had reduced. Because if it's really swollen, the mobility is going to be bad because it's the body stabilizing it. So we'll assume like 6 weeks later, limited swelling, still damaged capsule anteriorly. What we'll see is some ranges of motion will be hypermobile, particularly external rotation, horizontal abduction, and extension. Anything that was previously limited by the anterior joint capsule. So those will be probably hypermobile. Does that make sense? Actively, we may see some hypermobility in those directions as well. That's a little less predictable. But to just elaborate a little more, so like last semester it's a firm capsular end feel. But theoretically now we would know which part of the capsule is limiting us. So we do abduction, and if we're getting a firm capsular end feel, it's probably the inferior aspect. If we're doing this, it's probably the anterior aspect. Haley, was it your hand?
It's yes, but I just read something.
What'd you read? We all might benefit from it. What you got?
I saw, it says the tendons of the rotator cuff blend with the ligaments and glenoid labrum at their sites of attachment, so muscle contractions provide dynamic stability by tightening the static restraints.
You're reading on 568, right column, under stability, yes? Yeah. Yeah, I mean, that paragraph says everything I've said in the last 20 minutes, and it puts it into like 5 sentences, so it's probably just better to read that.
My question really was, when they contract, you were saying they enhance the stability of the joint, right? Okay, that was my question, but then I saw that, so I didn't.
Yeah, so somebody comes in with a hypermobility, we can't address the static restraints, but we can do a whole lot, especially at the shoulder for the dynamic. This is why, when we had an AC separation, we're like, we're out of luck, because you don't have any dynamic restraints. We got a lot we can do at the shoulder, at the glenohumeral joint, excuse me. All right, there's a concept we'll touch now. It has implications for your ortho patients, but we'll also, it'll be covered in neuro as well. And like a lot of other concepts, it has multiple different descriptions. So the terms neural overflow, irradiation, and concurrent activation potentiation all mean the same thing. They mean that there is some muscular overflow, some muscular drive from one joint to adjacent joints. This is why, if you make a fist, it enhances rotator cuff stability. Right? And that's protective. If you carry a heavy suitcase and your rotator cuff isn't active, your arm would come out of socket. But if you make a powerful fist and your gripper muscles start to activate, there is overflow up the kinetic chain to help stabilize or stiffen your shoulder. I've mentioned him before, but he has a lot of wonderful pearls of wisdom. Pavel Tsatsouline, who popularized kettlebells here. He's Russian. I think he's trained their special forces for years. He's written a number of books, and one of them is called The Naked Warrior, and he puts this principle to work. It's like if you're meeting somebody new for the first time, and you want to assess dominance over this person, here's what you do. You hide your other hand in your pocket, and you make a fist. And you make a really powerful fist. And then when you go to shake their hand, you crush it. rather than have a really limp hand and then go to shake his hand, and it's less crushing. And so all he was doing is applying the concept of neural overflow or irradiation or concurrent potentiation activation to assessing dominance. So we're going to do this. Try it limp and then try it like with a fist. So during the last fall's lab where we were testing strength with the dynamometers and we had that grip here versus here, Mr. Lameth and I gave this a shot, and we had, I don't remember how many pounds of force, but a meaningful difference in intentionally limp contralateral hand versus fist in the contralateral hand. And it made a measurable difference on the dynamometer. Okay, this is a really long, drawn-out explanation for an important point for your ortho patients. If you're trying to do joint mobilization or stretching, and you look at their hand, and they're like this, what's going to happen? You can't meaningfully stretch or mobilize the capsule because of this. So you need to make sure their arm feels well supported, make sure their hand is a limp noodle, and you'll get less cuff activation and better mobility, whether we're trying to treat the capsule or the muscles. But what if you put a cuff weight on your patient, cuff weight around the wrist, and you see them going through an exercise like this? Let's maybe change that. Either make a powerful fist, or maybe just have them hold on to something that requires that. And we'll elaborate more on that on Monday. Is that concept okay? Yes, ma'am.
Are all of those terms synonymous with cardiac?
mean the exact same thing. Frustratingly, a book will often use one of them and not acknowledge its synonymous terms. So you're like, well, is this the same thing? All the same. Other examples of this have been like force production in the extremities while using a mouth guard to clench your jaw. That seems to have quite a bit of overflow as well. And then for your neuro patients, again, next year you'll talk about this a little more. Is anybody going to introduce themselves to somebody and like hide their other hand?
Every
Every
time.
time.
I was just thinking, every time I'm going to shake somebody's hand, I'm going to be looking at what their other hand is doing. I'm going to call them out on it too. Are you making a little fist?
You're trying to assert
Are you going to start dominance right now?
When the boyfriend comes through,
I make a fist outside the pocket.
So
you're gonna tell him to take his hand.
this is like a rainy day read. It's so good. I think I actually first read it in a bookstore, and then after I finished reading it, I bought it. I'm like, this is amazing. So if you find it for like $2 on Amazon, you should get it and read it.
$2?
If this is 50, don't spend it. Borrow mine before you spend it. Get it used. Only $10.
I'm gonna buy a Kindle.
It's just interesting hearing what like other realms of the world do with some of the concepts we apply, because we wouldn't say assert dominance by making a fist with your other hand, but it's the same idea.
It's very Russian.
He's also brilliant if you get to listen to him on a podcast or watch him on anything. He's such a smart guy. Yeah, I think that's a very, I don't know, I don't want to point culturally to anybody, but it's sure. But what he says is so brilliant and wise for application to our profession as well. All right, so last two things before we break. Concave glenoid fossa faces laterally, anteriorly, and superiorly, which provides in itself minimum stability. But the direction it faces, like we covered on Monday in lab, is critical for the direction of our joint mobilization. So if the fossa faced straight laterally, we would mobilize by distracting that way and by doing anterior and posterior glides right here in the sagittal plane. But it doesn't. It faces a little bit anteriorly, 30 degrees anterior to the frontal plane. So accordingly, our distraction should occur 30 degrees anterior to the frontal plane, And our slide glide techniques should occur anteromedial and posterolateral. The direction of the concavity is what determines the direction of our joint mobility work. I'll say this again in a couple of slides, but moving in, oh, it's actually here too. The glenohumeral joint is considered to be more stable with less risk of impingement when strength training is performed in the scapular plane. A couple of things happen when we move in scaption. It's the position the arm wants to move in based upon the direction of the glenoid. The subacromial or suprahumeral space is maximized when we move in scaption as compared to moving in the cardinal planes, which prevents the risk of any impingement or pinching of the soft tissues that live there. So if we've got a patient with impingement-style shoulder pain, having them exercise in scaption tends to be helpful. They're less likely to irritate those sensitive tissues in scaption. But also, we're probably stronger there. So if your goal isn't to maintain the health of your supraspinatus tendon, that's fine. You'll still be able to express more force, particularly overhead, when moving in scaption versus moving in frontal plane abduction. Shoulder doesn't prefer this position. We won't be as strong, and it won't be as healthy. So here's the implication of that. We still measure strength in the cardinal planes. Our assessments need to be valid and reliable, so we do them in a consistent, clearly defined way, and that's the cardinal planes. But in between strength measures, when you're just providing exercise prescription, having your patient exercise in the scapular plane or in scaption probably is a better idea. Test in abduction, strength train in scaption. Yes, sir.
But Dr. Miller, what about all the people that want to do pull downs like this? They look cool.
Can I answer that in a few ways? Yeah. A lot of these descriptions are what's optimal for underlying tissue health, not always what's optimal for muscular development. If somebody's like, you know what, I feel much better lat activation, I'm not sure why they would, when I pull the bar down behind my head. Or, I've done this, because Rocky did pull-ups, 1 rep here, then 1 rep here. I'm like, oh, I want to do that. So that's how I started doing pull-ups. Like, somebody wants to do something great. But it's certainly not going to be stronger in that case, and it's certainly going to be worse for the shoulder. Also, that position where we're fully horizontally abducted and fully externally rotated and a little bit extended behind the head stresses what part of the capsule? Like, maximally stresses the anterior capsule. For somebody with an otherwise healthy shoulder capsule, whatever, like, do what you want to do. But for somebody who's got a history of hypermobility to the anterior capsule, that would be absolutely contraindicated. So, like, I guess I would be neutral with some people while still wanting to offer them a better suggestion, but it would be absolutely contraindicated for some patients. You know, like a lot of other things. Yes, ma'am.
So yesterday on lab, we were talking about potentially doing stretches in the scaption plane. But I was wondering, like, what would indicate that we would stretch in the scaption plane if there was an issue with the capsule? Like, if we were doing a test with the dummy and we realized that there is a capsule issue, why are we stretching treating the capsule?
So you're stretching, but you think there's a capsular issue, right?
So maybe I understood the scenario yesterday. There is a capsular issue, that's why it would not let it really stretch in one of the organs.
Yes, now I understand. So why are we talking about the capsule when he's doing an exercise? In order to move the arm, we still have to allow for the humeral head to slide or glide. So even if we're doing a strengthening exercise, in order to achieve this position, we need to have the necessary mobility and flexibility to get there. Right? We can't strengthen in a range of motion we don't have. So if the person had a history of lesion in the anterior capsule, we would want to avoid strength training positions that put them in that predisposing part of the range of motion. Another thing we would want to avoid, you want to strengthen your shoulder flexors and elbow extensors. If you've had a history of dislocation, we want to avoid putting you in the position that stresses it. Even though we're working musculature, we can still strengthen those muscles at a safer portion of the range of motion without subjecting your underlying tissues to undesirable stress. See you back in time.
So, Dr.
Yes, sir.
You probably had a question.
All right, we've done the AC, the SC, the GH. Spend the next piece of time looking at the scapula. So a lot of this you've heard, but this book gets into a little bit more depth on certain scapular movements, specifically for overhead motion. So it's one of the questions on the reading worksheet. All right, so if you've got your book open, page 570, figure 17.5. Are the motions of the scapula. So 17.5a is just frontal plane movements of elevation and depression, shrugging your shoulders and pushing them down. 17.5b shows protraction and retraction, which are transverse plane motions. Sometimes you'll see protraction referred to as abduction. It's not common, but it's out there. Along with humeral elevation and return to neutral, we see the motions of upward and downward rotation. Again, we name those motions for what the inferior angle does. So, protraction, the entirety of the medial border moves away from midline. That's protraction. Whereas upward rotation, it's just the inferior angle moving away primarily. So we name upward and downward rotation for the inferior angle, and that's the primary moving piece that we're going to see. In the transverse plane, we have internal and external rotation, and these are new terms this semester. So I'm going to read a sentence out of the paragraph right below, because I think it's really clear. 570, right column, and it's the one orange bullet point. Third line toward the end, it says, internal and external rotations are transverse plane motions in which the medial border lifts away from wings or approximates the rib cage. So, anybody ever seen, this is often in young kids, it's like the medial border of their scapula almost looks like it's not part of it. And if they put their hands on the floor, it's like the whole medial border becomes exposed. That's internal rotation, which we often call winging. Transverse plane rotation. That position, not desirable, if you think about what it does to the glenoid, not desirable for overhead reaching. Instead, if we're going to fully reach overhead, we don't want it to internally rotate. We need scapula to externally rotate to allow for full elevation of the arm. So those are new motions, internal and external rotation. We need external rotation for the arm to reach overhead. We did talk about the tilts, anterior and posterior tilting. For anterior tilting is coupled with extension, hyperextension. But posterior tilting, where if we had water in the supraspinous fossa, it spills backwards, posterior tilting is also necessary for the arm to reach overhead. So for full motion of the shoulder complex, the scapula needs to be really mobile. It not only upwardly rotates like we covered, but it externally rotates and posteriorly tilts. It positions the glenoid optimally to allow the arm to overhead. In a moment, we're going to talk about some structures that limit the scapula's ability to move. You can probably guess what it is, even if you didn't pick it up from the reading. So, if we need the scapula to upwardly rotate, I'm going to leave this off for now, and posteriorly tilt, we would need adequate flexibility of certain muscles to allow for this. Specifically, the antagonist muscle to that, right? Like if I need full elbow extension, I would need good flexibility of an antagonist muscle of extension. I need good brachialis flexibility. So if I need to upwardly rotate and posteriorly tilt, what muscle needs to lengthen during that?
Pectoralis minor.
Pec minor. Because what's pec minor do? It downwardly rotates and anteriorly tilts. So I need good pec minor flexibility to allow for this. Somebody's pec minor becomes adaptively shortened or tight or hyperactive, overhead motion is going to be a problem. More on that. Force couples for upward and downward rotation. This is a review. Upward rotator force couple is what? Upper trap. Lower trap. Serratus. Sounds like levator, that's what you meant. Downward rotation force couple.
Rhomboids.
Rhomboids.
Levator scap.
Levator scap.
Pectoralis minor.
Pec minor, perfect. Know your force couples. I mean, know everything, but know your force couples too. We talked about scapulohumeral rhythm first time. And the first time we talked about it, it was this kind of esoteric number. We're like 2 to 1. And now we understand the anatomy enough to explain these bullets a whole lot better. So scapulohumeral rhythm just describes the relationship between the humerus moving overhead and the scapula upwardly rotating. Those two things occur together. If we just take the big picture, and we think about the arm being elevated 180 degrees, approximately 2/3 of that is coming from the GH and 1/3 from the STA. Big picture, for every 2 degrees of humeral elevation, there's a corresponding degree of upward rotation. Big picture. Parenthetically, it's more like GH down low, 1 to 1 in the middle, and GH up high, but 2 to 1 is just kind of the accepted way we describe it. Supraspinatus is the clearest example, but it's not the only one. Supraspinatus originates in the supraspinous fossa, goes under the subacromial space, and attaches to the greater tubercle. What would happen if it contracted, and the scapula didn't move? We would get some impingement if the scapula didn't move. Yeah, we'd certainly get some impingement. What would happen to the force production of the supraspinatus as it got shorter and shorter and shorter? It would decrease, right? As the length of the muscle reduced, we would eventually hit a point right around 90 degrees where the supraspinatus was really far left on the length tension curve. Right? It was in a poor position for force production. It starts out in a great position, the muscle's long. We shorten it, and all of a sudden, bad position for force production. So, while the insertion moves toward the origin, upward rotation takes the origin and it moves it away from the insertion, which allows the muscle to remain at an optimal spot on the length tension curve. As those scapulohumeral muscles shorten, the scapula moves to get the origin away from the insertion so that they can maintain good force production, not just here, but overhead as well. Third reason, it helps to maintain the congruency of the humeral head and the fossa. That's one piece. The other piece of that is the inferior glide that holds the humeral head firmly on the fossa. And then lastly, and somebody mentioned this a moment ago, the structures that live in the subacromial space would impinge or pinch if we didn't get the acromion and get it out of the way. So it protects the structures that live in the suprahumeral or subacromial space. Speaking of, this was another question. What structures lie in the subacromial space? So if we look at a lateral view of the shoulder, we can see this region in here, above the humerus, suprahumeral, and below the acromion, subacromial. And there are a number of soft tissues that live there. So first thing, the coracoacromial arch is right here. It's comprised of both the acromion as well as the coracoacromial ligament. That's the roof of this region. The floor is the head of the humerus. Everything between the head of the humerus and the acromion, and you can see that gap right in there. All right, bone on top, bone below. We don't want to pinch soft tissues below those two bones or it'll be unpleasant. So the soft tissues that live there are, number one, the bursa, subacromial or subdeltoid, depending on where it is. The supraspinatus tendon, and maybe some of the muscle belly itself. So the supraspinatus tendon is in that region, and it's not super well vascularized. Muscles, great blood supply. Tendons, not as great of a blood supply. So one of the concerns is that over time, continuing to pinch or irritate the supraspinatus tendon leads to normal age-related changes in degeneration. And we'll see that individuals over 40 tend to have some degree of rotator cuff pathology. And it's just because the supraspinatus tendon, which lives there, tends to break down over time. I think, we don't need to turn to this, but I think our pain book cites a paper about shoulder MRIs in older adults. And it says 1 in 3 people over the age of 30 and 2 out of 3 people over the age of 70 have abnormal MRI findings related to their shoulder, including complete rotator cuff tear. So the supraspinatus tendon is just in a really tough spot. And we tend to see that the vast majority of rotator cuff injuries, rotator cuff tears, occur because of this anatomy here at the supraspinatus. So how do we maintain or maximize that space? What can we do? Or what does the body do? Maybe would be a better way of saying that. There's a few ways we maintain it. How do we maximize the subacromial space? Yeah, upward rotation of the scapula, absolutely. So one of the things we should be looking at and aware of is the serratus anterior muscle. It tends to be really important in that upward rotation force couple, and if it's not functioning properly, exercises for the serratus, absolutely critical, because number one, we upwardly rotate to maximize subacromial space.
Also the inferior glide of the humeral
Perfect.
head.
Inferior glide force couple. What is that force couple? This is going to be frustrating. Supraspinatus, infraspinatus, subscap teres minor. Yes, according to last semester's book. It's kind of an outlier there. I know. I'm sorry. I didn't write them. This semester, this text just says the its of the sips, infraspinatus, teres minor, subscap, and not the supraspinatus. That tends to be a little bit more common. I don't care what you put. It's the rotator cuff muscles, maybe including, maybe not including the supraspinatus. I'm sorry. But we prevent pinching by, number one, getting the acromion out of the way, and number two, pulling the humeral head downward. One more. And this is something we can instruct our patients, and we might even call this 3 and 4. You've heard me use this cue in lab a few times. Yeah, absolutely. So, can you elaborate a little bit?
You just said external rotation.
Good elaboration. So, when your patient does an activity and raises the arm, whether it's a movement, whether it's resisted, we should encourage them to be fully externally rotated. And so the cue we'll use in lab a lot starting next week is lead with the thumb. Because generally, if your patient leads with the thumb in an overhead motion, it externally rotates their scapula. I realize we can do a lot of stuff at the forearm, but your patient's not going to dissociate their forearm from their shoulder. Lead with the thumb. Incidentally, it's a good cue to give even starting with day 1 when they're just maybe getting out of a sling, because then it becomes a habit for them. They think about leading with the thumb. And then if you're talking to your patient and you say lead with your thumb, it reinforces it for another patient who might not be working with you but still hears you. So leading with the thumb promotes external rotation, which allows the greater tubercle to clear the coracoacromial arch. One more, and I guess we can think about it as a 4th. It sort of goes with our verbal cueing for number 3. One more thing we can do to maximize the subacromial space. Louder.
Scaption.
Yeah, moving scaption. Because the glenohumeral joint is considered to be more stable with less risk of soft tissue impingement when strength training is performed in the scapular plane. So these are nice suggestions for everybody, but certainly of higher importance for your patient who either has or is predisposed to impingement style symptoms. So we're going to make sure the scapula is upwardly rotating. We're going to make sure the rotator cuff is strong because it's responsible for the inferior glide. Either the sits muscles collectively, all 4, or the its of the sits. We're going to make sure that we're cueing and promoting correct exercise technique with regard to externally rotating, leading with the thumb for all overhead movements. And then even though we're going to do our assessments, GONI MMT, in the cardinal planes, whether we're stretching or strengthening, moving in scaption will maximize the subacromial space. Thank you. Just another view of that subacromial space. So, right between here, during elevation of the arm, the humerus needs to externally rotate to allow the greater tubercle to clear the coracoacromial arch. It's just what I said last slide. And then as far as muscles with optimal orientation to externally rotate, it's really our infraspinatus and teres minor. The role of the posterior delt in comparison to those is much less, at least at most joint angles. And so your text just describes weakness or inadequate external rotation range of motion may result in impingements because now we can't clear the arch as we elevate the arm. Incidentally, if you think about the fiber orientation of the infraspinatus versus the teres minor, the infraspinatus fibers are a little bit more horizontal. It functions really well when the arm is adducted to the side. The teres minor tends to function a little better than the infraspinatus when the arm is abducted. So our humerus angle of abduction might determine in part which one of those muscles takes over the majority of the role in external rotation, with the infraspinatus being better targeted with the arm adducted and the teres minor with the arm abducted. What should we do? Probably both. At early stages of rehab, if we have range of motion limitations, we'd have to do external rotation work here. But at later stages, we should do external rotation work here because this is a much more functional motor pattern. How many of us externally rotate like this? No. But it's critical for the infraspinatus, and we probably can't do this until we can do this. So targets different muscles, they're both really important. I haven't noticed this about this picture until now, but we see that inferior redundancy there in the joint capsule. That's nice because it's not usually depicted correctly. All right, we alluded to this. This posture, super common, right? These are the people who, if you're walking behind them, you can kind of see their palms because of a myriad of dysfunction in the upper extremity. So this probably includes a certain degree of the following. Number one, the thoracic spine is rounded, increased kyphosis. That by itself is problematic. If you just flex your thoracic spine, overhead reaching is virtually impossible. We need the thoracic spine to extend a little bit to allow us to reach overhead. Concurrent with that, decreased posterior tilting and external rotation of the scapula also limits overhead reaching. In this posture, if we think about what happens down the chain as a result of this thoracic and scapular posture, the humeri internally rotate and abduct just a little bit. And so we end up in this position. And then it gets held here with adaptive shortening of the following muscles, one of which we talked about already. Decreased flexibility of the pec minor. As that shortens, we are held in an anteriorly tilted scapular position. We're held in downward rotation. Other muscles that may hold us there, the levator, the scalenes, and the glenohumeral internal rotators. And we will address the majority of those in line. The antagonist muscles become weakened as well, and we see weakening of the serratus, trapezius, and external rotators. The downward rotators tighten, the upward rotators weaken. The internal rotators tighten, the external rotators weaken. And if you can kind of visualize this posture, we should be able to arrive at that without memorizing it. If my shoulders spend all day in internal rotation, those internal rotator muscles may adaptively shorten, and those external rotator muscles probably not going to be super strong and active. If my pec minor holds me in downward rotation at the scapula, my downward rotators, they're going to become hyperactive or tight. My upward rotators, probably not so much. Right, so if you can picture this, a lot of the dysfunctions we described should be relatively self-evident. Each of the joints we're going to cover over the next 5 weeks has an arthrokinematic slide, but all of this is going back to chapter 5. The glenoid fossa faces primarily laterally, somewhat anteriorly, about 30 degrees anterior to the frontal plane, and slightly upward. So this is what we're working with for all of our joint mobility. Okay, so resting, loose pack, open position, position of comfort. This is what your book says. 55 abduction and then 30 horizontal adduction. In other words, about 55 of scaption. Put 2 pillows under your arm, sit in a recliner, and this is what you would do if your shoulder really hurt. So for most of our techniques, that's going to be about our starting position. Subject to change as needed, but generally we want to begin our joint mobilization from the resting or loose pack position. Convex humeral head is moving within a concave glenoid fossa. And we know concave convex. When a convexity moves on a concavity, the arthro and osteokinematic motions are in opposite directions. In other words, at the shoulder. For the arm to go up, abduction, the humeral head slides or glides down. In order for the arm to go back to wind up a hug, the humeral head slides or glides anteriorly. And for the arm to come forward to close down the hug, the humeral head slides or glides posteriorly. We have 4 techniques. Number 1, distraction. Again, perpendicular to the concavity. It's going to be for general mobility. Inferior glide, according to your text, is to increase abduction, but it increases all elevation of the arm, whether it's scaption or flexion or abduction. The humeral head has to slide or glide down. We had 2 techniques to improve inferior glide. One was with the arm at the side, and one was with the arm abducted 90. Posterior glide is what everybody calls it, but really, how should we describe it? Posterolateral glide, yeah. Because we need to be moving parallel to the concave glenoid fossa. And the glenoid fossa is not straight forward and back, right? Somewhat anterior. Posterior glide is necessary for this, for the arm to come forward to close down the hug. Flexion, internal rotation. And then we added this to your text, horizontal adduction. Anterior glide, just the opposite. For us to wind it up, increase extension, external rotation, and then we added to your text, horizontal abduction. And again, it would be better described anteromedial rather than just anterior. Sort of connected to the direction the glenoid faces. I've probably talked about anterior shoulder dislocations like 4 or 5 times now. Why is it that I keep talking about anterior dislocations and not other directions? Like, why not superior dislocations? What's that? Yeah, I can't really go very far up. The bony anatomy limits the degree to which we can get a superiorly directed force. Now I'm thinking about the glenoid position. Anterior dislocations may be more prevalent, because if you think about the posterior lip of the glenoid might protect us a little bit against posterior migration of the humeral head. But to kind of apply the concept, what would a mechanism of injury be for a posterior humeral head dislocation? I've talked about anterior a bunch. How about for posterior?
You have to be like that.
Be like this, and then the force would go like that. What other options? It feels like the anterior dislocation.
Oh,
For posterior. That would do it.
Hanging. You trying
Yeah.
to catch yourself and fall.
A force that went here, like a fall on an outstretched hand, like a fall this way. So kind of the opposite of that anterior dislocation, but less common. There's more stability superiorly and posteriorly than there is anteriorly. I think we have a video of an inferior dislocation to watch over the summer too. Not pleasant. Okay. The end of each of the readings for this semester is going to be the section called Referred Pain and Nerve Disorders in the Shoulder. And then that middle third is all going to be pathologies for the summer. The last third is what we'll be covering in lab. Last third will all be these lab exercises. So there are a lot of nervous system related reasons that an individual might present with shoulder pain. You flip back to 401 in your text for a second. Again, dermatomes are areas of skin associated with different nerve roots. Dermatomes are the pictures on the top. Dermatome person. And you can see different areas of skin shaded and associated with a different nerve root irritation. What nerve roots contribute to the skin in the shoulder region? C4, C5. So if somebody has nerve root compression of C4, C5, they might present with neck pain, but it might be referring into the shoulder region. It might be numbness, might be paresthesias, might just be a little bit of irritability. But we knew that one already because if we were screening sensation, C4, C5, C6, remember this one, C7, C8, and T1. So C4 and C5 may cause discomfort in the shoulder region. There are organs as well, the diaphragm, heart, and gallbladder, that can refer pain into the area. What's a way we can, not conclusively, but suspect that pain is coming from an organ rather than the musculoskeletal system? It's a big flag for us.
Like blood count.
Yeah, if you had lab work. But what about in therapy?
Symptoms. Like,
What kind of symptoms would say, you know what, I don't think this is coming from your supraspinatus? Ask it this way. If it's coming from the supraspinatus, or there's joint compression or arthritic changes, and you really push them hard in therapy, what are their symptoms going to be? If you overdo it, their symptoms are going to be worse. And then if they rest for 3 or 4 days, how are they going to feel? Probably better. If it's the musculoskeletal system, you can expect, predictably, that we'll be able to change the symptom behavior based on loading. Right? If the muscle's partially torn and you have it contract, it's probably going to hurt. If you elongate it, it's probably going to hurt. But if you rest it, it'll probably feel better. The musculoskeletal system, by loading it or stressing it, we can change symptom behavior. If there's something coming from the gallbladder, are we going to be as successful in changing symptom behavior? No, it hurts when I rest, it hurts when I move, it hurts when I sleep, all that. So there are nerve roots as well as organs that can create discomfort in the shoulder region. The brachial plexus also can contribute to pain in the shoulder region and into the upper extremity. This is going to be a discussion much later in the semester, so I'm going to be brief now. And if your understanding of it today is not great, that's fine. We are going to come back to this. But the brachial plexus, starting at the nerve roots, ending at the hand, has to travel through a number of different structures where it can be irritated. You've talked quite a bit with Dr. Brickley about the nerve roots, right? They exit the spine. They can be irritated in the foramen. They might contribute to pain in the shoulder. But the trunks, the divisions, and the cords also have to pass through areas of the body where they can be irritated. The trunks have to pass between the scalenes. We talked about this. Between the anterior and middle scalenes emerge the trunks of the brachial plexus. So in an individual who's an accessory breather and has very developed scalenes, we might see paresthesias in the hand. The divisions have to pass between the clavicle and the first rib. So if there was a clavicular fracture and it didn't heal right, or if the first rib is elevated, or if for any other reason that space is narrowed, the divisions of the plexus may be irritated. Lastly, the cords pass right below the coracoid and behind the pec minor. So in somebody who's got a tight pec minor because of this type of posture, they might have some brachial plexus compression there. Especially, this sometimes applies to a few of us, if you lay down like on a foam roll with your arms up like this and they start to fall asleep, that's probably the plexus passing under the pec minor. So there are nerve compressions, I realize this is the neck, but in the neck and shoulder complex region that can occur directly to the plexus. Not the peripheral nerves, not the terminal nerves, just the plexus itself. There's 3 other commonly entrapped or irritated nerves at the shoulder. The first is the suprascapular. So suprascapular coming off the superior trunk, C5, C6, joined together superior trunk. There's that little notch on the scapula. That's where the suprascapular nerve goes. Any compression from the top, downward compression, might create some mechanical compression to the suprascapular nerve. The radial nerve, a little bit more common. Super vulnerable to injury from, number one, mid-shaft humeral fractures. Mid-shaft humeral fractures. And number two, Saturday night palsy or crutch palsy, which is axillary compression. So, by some accounts, you'll see the axillary nerve can be irritated here, but if you have to choose between the axillary and the radial nerve, the one most likely to be irritated in the axilla is the radial nerve. Some books say axillary as well, but radial is the most correct choice if you've got to make a distinction. So let's say somebody has a mid-shaft humeral fracture and the radius runs right in the radial notch of the humerus. It's named for it. Right down at that. And there's a laceration of the radial nerve. What is their hand and wrist position going to look like? So what's their grip going to look like? Why? Yeah. If we can't extend, we can't manage the length-tension relationship of these finger muscles. And so this becomes our grip. I saw this in a board exam review book once. What type of assistive device might that person end up needing? Take that. Let's say they end up down the road still with a radial nerve lesion, but they end up breaking a leg and needing an assistive device because they're not weight bearing. What type of assistive devices might they benefit from if this is their grip because they have a comorbidity of a radial nerve lesion? Would standard axillary crutches work well? No. Standard walker work well? Just give him a wheelchair. I said scooter. It's the safest choice, right? What else if, let's say they're 25 and they don't want to ride around the community in a wheelchair or a scooter. What can we do?
Platform walker.
Yeah, one more time. Platform walker. Let's get the wrist and hand out of it and maybe give them a platform attachment on one side so that they're weight bearing through here and we can just not worry about that. So some of these have implications kind of beyond just the injury itself. So radial nerve, subject to be damaged with mid-shaft humeral fractures, but if we go up the chain a little bit, the proximal end of the humerus is where the axillary nerve wraps around. If we have a dislocation of the humerus, or sometimes even a reduction, putting it back, or a fracture of the proximal humerus, like the neck, that might irritate the axillary nerve. What's the big manifestation of that going to be if the patient has an axillary nerve issue? Abduction is going to be profoundly limited, right? We are going to talk about the nerves on the last slide of each one of the joints, but then at the end of the term, we're going to make the nerves the star, and we're going to trace them from top to bottom. So what you'll see here is that we're going to talk about the radial nerve at the shoulder, and then again at the wrist and hand, and it's going to be disconnected. But later on, we're going to connect it. We're going to draw it out from neck to hand and kind of course it through the entirety of the path. So it's reductionist now. It comes together later. All right. This is what we're covering. We've already gotten the first half of it. So next week, we've got this, as well as all of these figures from your text. It's going to be fun. Questions about the shoulder? Excited? Anybody else excited about the shoulder? Yeah, okay. Just me. All right. Take 14 minutes. We will start back at 10 o'clock.